So what about sleep? What can go wrong? I'll just do a quick list of things. Actually, I think there's a few slides on this, but so there's lots of different things with sleep. We thought to look at sleep because it hadn't really been done before. There's one study that was done before ours, and there's still more to be done. The different, when you think about sleep disorders, there are different categories of sleep disorders. The first category is insomnia, meaning, I think I'll go through the next slide actually. Then the sleep-related breathing disorders, central disorders, circadian rhythm disorders, parasomnias, and sleep-related movement disorders. So just the common ones are coming. Forgetting the order of my slides. This is how we measure sleep. So it's a sleep study. You can see he's got the leads attached to his head, and that measures EEG. So that identifies when you are asleep and when you are awake, and when you're in REM sleep. And then there's all these monitors, so to do with how, when you're making thoracoabdominal movements related to, are you making an effort to breathe, a saturation monitor to measure your oxygen, and there are other things. This is what it looks like on the recording. This is an example of showing sleep apnea, where you see that their oxygen, let's try this first. This is obstructive sleep apnea. So their oxygen is dipping as their respiratory effort is not so good, and then they sort of wake up, they arouse. You can see they wake up here, and then their respiratory effort overcomes the obstruction of their breathing, and their oxygen goes back up again. OSA is actually quite common in society, and there are a number of risk factors that put people at more risk, which are called traditional risk factors for obstructive sleep apnea, to do with age and weight, and just sort of your anatomy, to do with your neck circumference and what your oropharynx looks like. And some prevalence studies have shown that up to 24% of men and 9% of women can have obstructive sleep apnea, although they did define it being present at a mild degree, and that this in their study dropped to 4% and 2% when you add a measure of are you sleepy in the daytime. So we incorporated those things in our study. So circadian rhythm is the rhythm of when you're asleep versus awake, and in general there are sort of biological reasons that you go to sleep. There are homeostatic factors, meaning there are factors that like a biological factor that, such as melatonin, that comes out in the evening when it is dark, and entrained to the environment, to do with light and dark, that makes you fall asleep. And to discuss the details a bit complicated, but in general there are factors that make you go to sleep and factors that make you wake up, and the one inhibits the other, so that you're not falling asleep and waking up all the time. So when you're awake, you're awake. When you're asleep, you're asleep. And there's a switch. So at some point you'll go from awake to sleep. At some point you go to sleep to awake. And there are factors that sort of, will make that change happen. So hopefully you have a circadian rhythm where you sleep, you restore your sleep debt, you wake up feeling refreshed, and then you accumulate sleep debt due to these factors over the course of the day, and then you sleep again. But if you have a disorder in your circadian rhythm, you might not do that. And so there's various disorders you might have. One is where you sleep a bit early and wake up a bit early. The other is when you sleep a bit late and wake up a bit late. And there's one called a regular sleep-wake pattern, where you just have naps throughout the day and don't sleep during the night very well either. Another thing that might happen would be a sleep-related movement disorders, and the common one is restless leg syndrome, which has a diagnostic sort of questionnaire. There's not really a test that we can do about that, although it is often associated with periodic leg movements of sleep. They're not really, they're kind of separate disorders. In periodic leg movements of sleep, you might give a history of your leg kicking out at night. A lot of the time people have these and aren't aware of them, and they're not a problem. Sometimes they are a problem, and there's a definition of when it becomes a periodic leg movements of sleep disorder, and that is to do with how often it happens and also whether it disrupts your sleep and causes difficulties during the day. So sleep pathology and mitochondrial disease. Before our study, which is a small study as well, there's only one study that's been done prospectively, meaning you you recruit patients without known sleep disorders and look at them to see if they've got a problem. So this is one study that was done with 20 patients with CPEO of different types of mutations, both in mitochondrial DNA and also in nuclear DNA. There were a few with POLG. And they underwent a home-based sleep study, so they took all that equipment home. They did lots of questionnaires, and again, it showed that people were very tired on the fatigue scale. They did different fatigue scale compared to the last one with mitochondrial disease, and that some of them had excessive daytime sleepiness, so the tendency to sort of doze off, and a lot of them felt that their fatigue, impacted on their function. Their sleep impacted on their function. A lot of them had symptoms of depression, and they had quite a high rate of restless leg syndrome, and 20% had sleep apnea, and that was all central sleep apnea. So there's two types of sleep apnea. One is obstructive, where you get obstruction of the proximal airway, and you breathe in order to overcome that. You rouse and you overcome it and fall asleep again. The other one is central, where there's no effort at all from your breathing muscles. It just sort of gets switched off. And that often is related to either cardiac failure or central mechanisms to do with brain pathology. And the patients in this study, the ones that had this problem, I think were all, they're all quite disabled, and I think that a couple of them did have a more essential phenotype of disease, meaning they had some ataxia and other features. This is just a quick thing to say that, there's no studies done in circadian rhythm in patients with mitochondrial disease. They have done a study in flies where they wondered whether there may be some circadian rhythm impairment in flies, a fly model with mitochondrial disease. So it remains a question as to whether that's a possibility. So in our study, we performed it a while ago, 2015. There were 16 patients with primary mitochondrial disease, but only 5 genetically confirmed, and the majority of patients had mitochondrial myopathy on biopsy, actually. Again, very fatigued on both of those scales, and they correlated well, meaning that there was a statistical significance that the patients that reported fatigue on one scale would report it on the other one, and there was no one that didn't report fatigue they think that it was more sensitive on the fatigue severity scale. So there's one patient, I think, on the fatigue severity scale that didn't meet criteria on the FIS. 38% had excessive daytime sleepiness, so that's that Epworth sleepiness scale of propensity to fall asleep during the day. 75% had subjectively poor sleep on a different scale. There were 44% that had depressive features on the Beck depression scale. It's not a diagnostic scale for depression, but it can detect depressive features. And the patients that had reported that they had a diagnosis of depression previously both had depressive features in the diagnostic range. They had fatigability on sit-to-stand test more than a population of normal patients. So their time that they took to stand up, those repeated times, were significantly prolonged. And that's been shown in another study I didn't put in here, but of Mito patients, that there is that sort of fatigability on the sit-to-stand test. And interestingly, it wasn't really related to a presence of myopathy. I thought maybe the muscle patients would have a prolonged sit-to-stand time, but it was all, multiple different types of patients, being the patients that didn't have myopathy also had this problem. The main thing we found was obstructive sleep apnea, which was different from the study before, actually. And it was quite a lot of patients. About half of the patients had obstructive sleep apnea, although most of them were mild in severity, and only one of them was moderate to severe. And we didn't really find central sleep apnea like the other study did, but I think our patients were a little bit different. We had more patients with myopathy and less patients with central sort of disease, and there were a few other small differences. I guess the question is, because it's such small populations, whether taken collectively would be the right approach, because perhaps it's somewhere in the middle of the two things that we found. And a bigger study would be helpful to sort of figure that out a bit more. In our study, traditional risk factors weren't really there. So our patients weren't obese. They didn't have, funny anatomy. And although myopathy didn't predict it, it was trending to significance, that the patients with myopathy were nearly more likely to have obstructive sleep apnea. So I think if we had more numbers, we might have found that that was the case, and that would make sense because, respiratory muscle weakness does convey a risk, although it's not to obstructive sleep apnea so much, it's more to hypoventilation. And so I guess maybe that's not there. Because hypoventilation, they measure it slightly differently to do with the CO2 levels. But part of measuring obstructive sleep apnea is, other than when you have a complete apnea, is a hypopnea, where you don't expand your chest as much. So I guess it could have a bit of crossover. So we also found that the excessive daytime somnolence Epworth Sleepiness Scale wasn't significant, but was trending as well. It was close to significant, so in predicting patients with obstructive sleep apnea. And that's the case in the general community, that if you've got an ESS score over 10, it's helpful. ESS over 16 means, you probably have quite significant disease from a sleep apnea point of view. So, and it has a really good translatability to the clinic. So it's probably useful in asking the question there. In order to think about, would a sleep study be helpful or not? And as I said, most of them were mild. The reason that we think, the question about whether mild to severity sleep apnea is important is related to, if you have mild sleep apnea, do you treat it with CPAP? And, does that really impact on your experience of fatigue? And there are a few studies done now in mild obstructive sleep apnea in the general community. One showing that maybe some of the cognitive factors to do with sleep apnea might improve when you treat mild sleep apnea. We know that treating moderate to severe sleep apnea is helpful. It's just those cases are mild. And then there's another one that's come out more recently that suggests, it might be worth doing because there could be a measurable difference.